Again, welcome everyone. Thank you for being here. And on behalf of NAC, I want to welcome you to our June webinar, Caregiver Training Services Utilization, Impact, and Implementation. So before we begin, just a few, housekeeping notes. Today's session will be recorded, and we will be sharing the recording and slides with everyone afterwards. And also, if you want to look at all of the speakers' bios, you can check out the Zoom event link. And then we do have a Q&A session at the end of the webinar. So if at any point you have a question, please drop it in the Q&A box, and then we will set aside time at the end of the webinar to answer as many as we can. Next slide. So here is how our time will flow together. I'll begin with a brief introduction of the National Alliance for Caregiving, or NAC for short, and then I'll set the context by sharing some insights from our Caregiving in the U.S. 2025 report, which is a nationally representative study of family caregivers. I'll be sharing specific points around how caregivers are navigating the healthcare system and whether they have the tools and resources they need within the system. And I'll also be sharing some voices from our work with cancer and transplant caregivers, an important focus area for us at NAC. Next slide. We'll also be hearing from Anita, who cares for her mom, and because no statistics can fully capture what this role feels like, and we'll have her ground the conversation. We'll follow up. If you could go back one slide, Mike, my bad. We'll also hear from AARP on how Medicare's training services codes are being used and and how we can grow their impact, followed by Rush Medical University's incredible work supporting family caregivers and their efforts to implement these CTS codes into their ongoing efforts. And finally, we'll close with your questions, so please again add them to the Q&A box. So let's dive in. Next slide. So a little bit about us first. Next slide. The National Alliance for Caregiving has been around for the past 3 decades, and our work is, and our mission is to transform how the country is valuing the 63 million family caregivers who show up day in and day out for their families and their communities. Our work centers on 3 core priorities: caregiver health and wellness, economic inclusion, and building caregiver-friendly communities. Very specifically, this peer learning event is part of our cancer and transplant work, 2 large cross-sector initiatives where we are whose work focuses on helping or advancing the recognition, inclusion, and support of family caregivers in cancer and transplant through research, policy, advocacy, education, storytelling, and peer learning events like this. If you'd like to learn a little more about those efforts, I encourage you to reach out to us. At the end, we'll have our contact information. Next slide. So I want to start with this number, and that is that from the caregiving in the U.S., we know that over 1/3 of family caregivers say they want policies that require healthcare professionals to assess their needs, to ask them about what they need, not just about the patient. And this tells us something really simple but important, that caregivers want to be seen and recognized by the care team. Next slide. And the reason for this might be that family caregivers carry a lot of healthcare and medical responsibilities. We see that 7 in 10 monitor the severity of their care recipient's condition. More than 55% take on medical or nursing tasks. This includes anything from wound care, injections, managing complex medication regimes, etc. Yet only 22% are receiving any kind of training for these specific tasks, and therefore we see that a little more than half describe their situation as quite intense. And so the challenge here and the takeaway is that we have high responsibility paired with little or inconsistent support. Next slide. I want to share this quote here from one of our cancer caregivers, and that is, this phrase of "there's no roadmap" really captures the critical gap in our healthcare system. Next slide. And all of these responsibilities and demands really take a toll. 1 in 5 family caregivers rate their their health as poor, and this impact is even greater for those living with their care recipients. Nearly half say that that report a high physical strain, and more than that, 64% report emotional strain. So the strain is real, it's widespread, and it's preventable when healthcare systems treat family caregivers as partners and rather than visitors. Next slide. Here we have another quote from a transplant caregiver who describes caring for her husband who received a stem cell transplant and using a port to provide his medication at home, and talking about how this wasn't easy and how these responsibilities weigh on family caregivers. Next slide. So what do family caregivers actually need? Our caregiving in the US report also asks this, and they tell us quite clearly. 30% want help managing emotional and physical stress. 27% want training to keep their loved ones safe and at home. And about a quarter need help navigating paperwork and eligibility. And we also see that coordinating this care is quite difficult. So none of this is out of reach. This is really clear for what family caregivers need. And one of the big reasons why we're having this webinar in terms of what are the opportunities to provide family caregivers with the training, the resources, and the education that they need. Next slide. And finally, I want to close this section with a quote from a rare disease caregiver that really, excuse me, balances the difficult statistics of the impact and the weight of caregiving and their caregiving role with wanting to step up for their family, really putting a lot of love and effort into what they do, but really asking the system for support. So Pavarthi says, nothing fulfills our lives more than caring for our loved one. But in order for us to sustain that care, to keep them out of the hospital, we really need to sustain ourselves. And so that is that's what's at heart of today's conversation, supporting family caregivers and giving this support to them so that they can fulfill their caregiving role. Next slide. With that, I am honored to turn it over to Anita, who will share her experience caring for her mom. And her story will ground us on really what is at stake and why advancing caregiver support not only should be important to all of us, but requires all of us. So Anita, thank you for being with us today.
Thank you. And thank you for that introduction because it does represent the lived experience. So, good afternoon, everyone. I'm Anita, and for the past 3 years, I've been a full-time caregiver for my 83-year-old mother. She lives with total blindness, dementia, and multiple cancers. So, before stepping into this role, I spent more than exit. I retired early when it became clear that even with multiple care arrangements, I couldn't meet the demands of both the job and my mother's needs. So that transition from executive leadership to full-time caregiver, it was abrupt, unplanned, and like many caregivers, I entered it without formal training. Just to put in perspective, for my mom's care, I became responsible for everything, including medication management, wound care, coordinating doctor's visits, monitoring symptoms, assisting with mobility, supporting her personal hygiene, preparing meals, completing physical therapy, exercises, performing cognitive and sensory activities that worked for someone living with both dementia and blindness, managing the household, which included handling her finances, and I served as her medical advocate and primary communicator with providers in the family. Finally, woven through all of that was the constant vigilance around fall prevention, emergency response, and the emotional labor of keeping her engaged, safe, and connected. I learned most of these skills way through trial and but the reality is that most of caregiver training happens under pressure in real time and because your patient needs you to figure it out. So, looking back, structured caregiver training would have changed everything for both of us. Clear guidance on the basics of patient care, how to take vitals, what symptoms require escalations, and how to safely transfer someone with limited mobility would have prevented injuries, reduced stress, and improved our quality of life. Training on dementia-friendly communication, cognitive stimulation, and meaningful engagement for someone who is blind would have helped me support her more thoroughly. And perhaps most importantly, I wish someone had taught me about how to care for myself while caring for her, how to recognize burnout, how to plan for respite, and how to navigate the emotional toll of this work. So, for me and for many others, meaningful caregiver education needs to be accessible, practical, and designed for real world caregiving, not just ideal scenarios. A strong training program would include, first and foremost, foundational health and safety skills like CPR, vitals management, symptom recognition, and emergency response. Second, activities of daily living such as bathing, dressing, toileting, feeding, medication management, and household safety. Third, disease-specific training such as modules tailored to dementia, blindness, cancer, and any other chronic conditions, including the challenges, mitigation strategies, and patient voice insights. Finally, caregiver well-being and sustainability information, such as burnout prevention, and agency resources. This kind of training doesn't just support caregivers, it strengthens families, reduces avoidable hospitalization, and improves outcomes for the people we love. I thank you all for what you've done on behalf of caregivers and practitioners, and for the opportunity to share my experience and contribute to this conversation about what caregivers truly need. So, with that, I'll turn it over to Rita.
Thank you so much, Anita, for sharing your lived experience and really helping to center that experience on what this discussion is about today. It's easy for us to share the numbers, to share the data, but listening to your story that I know represents the story of so many others is what really makes this issue so critical. Good afternoon to everyone on this call. Thank you for joining us. Thank you to our colleagues at the National Alliance for Caregiving and Resch Medical Center for joining us as we talk about this new, exciting, and really critically important opportunity to support caregivers who are doing so much. Next slide. From our work with the National Alliance for Caregiving in our most recent study, Caregiving in the U.S., we know that nearly 1 in 4 adults is a family caregiver. So we're looking at 63 million individuals in this country that are doing so many things, including the tasks that Anita talked about, as well as carrying that emotional strain in trying to perform those tasks. Next slide. We also know and we hear from caregivers every day that they're rarely receiving the training that is needed for that care. when we look at the large amount of individuals that are being asked to do so much, whether it's activities of daily living, behavioral management, and other types of modification, to know that only 11% receive formal training, it sounds an alarm that something has to be done. This is where we're very excited in work that we have done with ATI Advisory, my colleague Juliana, who you'll hear from shortly, to really look at what these Medicare caregiver training service codes can really, how they can really help support this effort, this critical need to support caregivers in this space. Next slide. What we hear from caregivers is that when training does happen, it is indeed often delivered by healthcare professionals. And that really is a range of healthcare professionals. And so we're looking at individuals who are nurses, physicians, occupational therapists, and you'll see the range there on the graph. We know that under these new billing codes, not all professionals that are delivering this type of training can be paid for training caregivers of Medicare enrollees, but many of them can. And I'm going to turn over now to Juliana, who will talk more about the findings from our report.
Hello, everyone, and thank you, Rita, for kicking that section off. We could go to the next slide, please. So in this section, I'm going to be talking a little bit about our most recent report on caregiver training services codes. But I want to start with a little bit of background on caregivers being represented in policies. So we can kind of click through this chart real quick. There's a few graphics. So as Rita mentioned, family caregivers, there's more family caregivers that need training. And we're seeing that family caregivers that receive it are being trained by their healthcare professionals. And that's something that the Centers for Medicare and Medicaid Services also noticed. And from CMS's physician fee schedule, we start to see caregivers being incorporated into policies. It started in 2017 with caregiver health risk assessments. And as time went on, those have expanded to be approved for telehealth services. And then in 2024, we see the introduction of caregiver training services, or CTS codes. And these are formal codes for healthcare professionals to be reimbursed for training family caregivers. And if we just click along one more, in 2025 and 2026, those have expanded further and have been permanently approved for telehealth services. So there is a clear action from CMS that shows caregivers should be integrated into healthcare systems and practices. We could go to the next slide, please. So once we knew that these codes were available and people were using them, we wanted to learn a little bit more about how providers were putting them into practice and what their impact was. So from our research, we aim to increase awareness about CTS codes and track the data of who is using those codes in the first year and a half of their availability. And we really wanted to learn from real experience of people implementing these codes from the ground. Because as we said, these are relatively new and it's a lot of work to scale codes, as we'll learn. So this was just a little bit of the reason why we wanted to look into the research or into our research. Next slide, please. This is just a brief overview of some of the caregiver training services codes that are available and that we use to start our research. So we have those caregiver health risk assessments that I mentioned, as well as the 3 different types of CTS codes, behavioral management codes that help to train caregivers to structure environment and support or reinforce desired behaviors. You have functional performance trainings to help facilitate ADLs or activities of daily living. And you have direct care strategy codes that help someone as their person deals with a chronic illness or condition. And you'll notice in this bottom half of this breakdown that there are codes for training for individual caregivers, as well as training for groups of caregivers, which makes determining what codes to use a little bit different from the traditional caregiver health risk assessment code, which is just for one caregiver. So we'll just continue on to the next slide. And I just want to briefly touch on our methodology. As I mentioned, we wanted to look at the data. We wanted to see how many codes were being used. So we used Medicare claims analysis to track the first year and a half or 6 quarters of CTS use. We also know that it's not just about numbers, it's also about real experience. And so we facilitated conversations with a variety of stakeholders to really understand what it takes to implement these codes and use them. So just some of the groups of stakeholders that we worked with closely on this research included healthcare professionals of all different types, family caregivers, advocacy groups, provider associations, billing vendors, health plans, and healthcare system leaders. We can go to the next slide, please. And so now the findings. To go over some of the numbers, we see that there has been a steady increase over the 6 quarters that CTS has been available. And each code has increased their use over these 6 quarters. You might see these numbers and say, oh, those look pretty low. But we were curious to see how these codes compare to other similar codes that have been introduced around the same time period. So for comparison, we also looked at principal illness navigation codes that were also introduced in 2024. And for those principal illness navigation codes, there were just over 15,000 codes in this same time period, whereas CTS codes were billed over 26,000 times. So that just shows that there is a really clear path and opportunity for expansion of these codes. We can go to the next slide. And before I pass it off to Rita to discuss some of the opportunities to advance CTS, I want to highlight the qualitative findings from our roundtable discussions and our one-on-one interviewers with stakeholders that really illustrate why our Medicare claims data looks the way it does. So these gaps were identified across stakeholder groups as being some of the reasons why individual providers or healthcare systems at large or health plans have either not put CTS codes into formal practice or into workflows or into systems. So this could be from awareness and communications, just the right people don't know about the codes, to coverage and reimbursement inconsistencies that make it a little bit uncertain for providers to use them, to provider education on family integration, just empowering the provider and educating the provider on what it is that family caregivers need, since a lot of providers didn't necessarily receive that training in their formal education. So now I'm going to pass it off to Rita to highlight some of the other findings around what we can do to move forward and advance these codes.
Thanks, Juliana. And as we go to the next slide, I think something that's important for us to think about, especially as we look at opportunities for implementation and utilization of these codes, is I want to go back to something I wrote down that Anita said. And she said, looking back, if she had access to these codes, what a difference, or access to the training, what a difference that would make on her journey and how she is caring for her mother and how she would be better able to care for herself. And so as we look at these opportunities, again, I want to stress the importance, whether you're a provider, you're an advocate, or a caregiver yourself, that we continue to center these lived experiences as we look towards these opportunities. And so we categorized our potential opportunities into 3 areas. The first is strategic communication. What we're hearing from providers, professionals, systems is that they don't even necessarily know that these codes exist. Or if they know that the codes exist, not really having the amount of education or insight into how to use those codes to better benefit caregivers who are taking care of their Medicare beneficiaries. And so we look to CMS, payers, as well as provider or associations and health systems to really look at how you can better move towards implementation. So for CMS, really looking at publishing and creating a single accessible guidance resource for CTS codes so that when providers do learn about these codes, there's an opportunity for them to know how to work within the system to better utilize them. For payers, notifying providers, making them even aware of the CTS codes and what the coverage policies look like within that payer resource. For provider associations, run information campaigns. How do we really work within these associations and the members within the associations to better educate them how they work for their own communities? An example that I will give is that AARP most recently has collaborated with the American Occupational Therapy Association. And through that, we did a webinar. AOTA was able to offer CEUs to their members to learn how, as an occupational therapist, they could use these codes. And from what I'm hearing from our partners there, that education has really been very helpful to occupational therapists that were interested and now are able to use yet another tool to provide training and get reimbursed, honestly, for things that they likely were already doing. And then again, for providers to act as internal champions within whatever setting that you're working in to really advocate for, yes, the training of caregivers, but the usage of these codes for that reimbursement perspective. Our next bucket is increasing access. So again, within CMS, simplifying the billing requirements that are related to that. And then from a payer perspective, really promoting universal coverage and policies across plan types. It's really important that that payer is an invested resource within the usage of these codes. Also creating incentives. How do we incentivize providers and other professionals to really be able to utilize these codes? And there's an opportunity for that both within CMS, for a payer perspective, as well as through provider associations. And with CMS in particular, really working to develop and potentially incorporate performance measures for caregiver training. These are just some of the ideas that we talk about within our research. Next slide. We also want to look at developing infrastructure. So what is the infrastructure that is needed to really promote the implementation and usage of these codes? From CMS, again, looking at utilizing a web presence to really highlight and feature the guidelines and also provide educational resources, both from a provider perspective, across plans and health systems. For payers, integrating that caregiver identification into enrollment. And so again, individuals are really centering that caregiver and acknowledging the presence of the caregiver. For provider associations, identifying and using use cases, creating resources, embedding them into existing tools and opportunities that you all are already utilizing. And then for health systems, developing screening tools and establishing referral pathways so that, again, all of the providers within a setting that are going to be touching that caregiver and that beneficiary will have that support. And then again, building capacity, broadening billing of eligibility for additional providers working with caregivers is a very critical piece. We recognize that many different providers are utilizing or supporting caregivers through various training mechanisms, and there should be an opportunity for them to be reimbursed as well. within provider associations, partnering with caregiver focused organizations as you look at capacity constraints. So, if you are in a provider setting, health system setting, who are the caregiver organizations within your community? Many of you are in this call now. How can we bridge that and work better from a health system or system perspective, building in the community aspect of that system where family caregivers live and breathe? And then again, with health systems, really intentionally embedding caregiver engagement strategies, making them a part of that clinical care model, that's really ensuring that training is occurring. And as I go, or as we move forward, I should say, I just want to again thank everyone on this call, and would like to turn it over to Stephanie.
Thank you, Rita. Hello, everyone. And thank you all for being here. Good morning, good afternoon, whoever you are. And I'll be talking a little bit. Our program manager and I, Diane, will be speaking a little bit about the implementation of these CTS codes here at Rush. So that's a picture there of our Rush University Medical Center. We're a large university health system. And of course, want to acknowledge all of you for being here and love seeing those in the chat, especially those saying they are caregivers themselves and the once and future caregiver. And I think we are also familiar with that and especially appreciated Anita's lived experience. So first to just acknowledge our funder, the John A. Hartford Foundation, in supporting us in this work. So we can go on to the next slide. Just to give a quick introduction of the way this has worked at Rush. So the way these codes are being implemented at Rush right now is through a partnership with Rush at Home, which is our house calls program. It's primary care offered at home for people on Chicago's west side and nearby suburbs. I know you probably can't read all of that on the left, do not worry. This program consists of primary care providers as well as certified medical assistants, social workers, and nurses providing direct care in the home to support and keep adults healthy and comfortable right where they are at their home. To qualify for Rush at Home, these adults must have 2 or more chronic conditions and live in the qualifying zip code areas. So when the Rush at Home team goes out and sees someone at home, they see a patient at home and identifies any type of need for caregiver support, they send a referral over to Caring for Caregivers. On the right-hand side, you will see our flyer, which describes our program and the 3 elements that make up our model. And these codes at this time are being used under the first element, which again, I know it may be hard to see, but that first element is skill building meetings designed to support caregivers in their educational needs, under which they're learning skills to keep them healthy and well-informed. And so early implementation of these caregiver training services codes is happening through this partnership at Rush. And I'll just briefly touch on the next slide on the CARE Act, which many of you I know are familiar with, but this is enacted into law, of course, in most places at this time, and it indicates that when a patient, of course, is hospitalized, they need to be asked if they have a family caregiver, and that person needs to be entered into the electronic health record. Not only that, they need to be notified when their person is about to be sent home and need to be offered training. And on the right, just briefly again, to show you the 4 M's of an age-friendly health system, which I know you all are familiar with. But our Caring for Caregivers model is really rooted in the CARE Act as well as the 4 M's. And all of the 4 M's are infused in our work with caregivers, with most of our focus being on what matters, but that in turn supporting the other M's as well. And on the next slide, I'll just briefly review our key areas. We want to make sure that caregivers are identified and recorded, again, in compliance with the CARE Act. We work very hard to understand and assess the needs of that family caregiver, utilizing a strengths-based approach. And finally, to actually assist them once we've identified those needs to based on what matters to assist them identify resources and develop a very individualized plan for them for the future. So to transition into kind of how we got started with utilizing the codes here, on the next slide, we'll talk about our compliance department. So they took a look, of course, they have to review any new codes that come through for Medicare billing. So they took a look at this, utilizing the Medicare coverage database and making sure that the codes are implemented consistently, that they're being used right, that they're being attached to the right patient record, that it's going to the right place for billing, and that billing is actually going through. And so from that point, Revenue Integrity then integrated the codes into our electronic health record system, which here is Epic, and making sure that it's supported again and going to the right place and really falling under those value units. And this in turn supported the revenue cycle. That team then worked with compliance to understand the documentation requirements and just again making sure that everything is going to the right place and moving smoothly. And briefly on the next slide, we'll discuss the caregiver behavior management training codes. So these codes allow all clinicians, as listed there, to bill for services that involve training a particular patient's caregiver or caregivers in interventions to help support them. And so just to mention that advanced practice providers such as nurse practitioners and physician's assistants, as mentioned previously, those folks were doing a lot of this training. And so this is allowing them to bill for this service, of course, through the care recipients chart. These codes identify the efforts of these individuals, of these providers to train the caregivers regarding intervention that they may use to manage the patient's or care recipient's disease or illnesses. And we'll just very briefly on the next slide show you, I won't read them all, but just a few examples of diagnoses that can be used and what types of diagnoses would qualify for the billing. And again, these are diagnoses, of course, for the care recipient and not the caregiver. And this would allow the provider to then bill. And I'll turn it to Diane.
Thank you, Stephanie. We'll go to the next slide, please. So as Stephanie mentioned, we are partnering with our Rush at Home program. And I want to kind of note that we really put a lot of time and effort into trying to establish a clinic that we would be able to implement and initiate these codes. We've been talking about this and working internally with our teams at Rush to really get this going. As the caregiver support model at Rush, it was kind of our responsibility to get these things going because we have the most invested in caregiver support. So our Rush at Home program has always been a big support of our model and also a big referring clinic for sending their caregivers in need over to us. So we finally landed on this, but it still took quite a bit of time because our team, our Caring for Caregivers team, when we want to initiate something, a service for caregivers, we just go ahead and we move forward because we have the autonomy to do so. This is different where we have to really partner with a clinic or clinics within our system. And I think anyone that has understanding or experience in working with a large health system, those things do not happen quickly. It's very difficult to move things along. They happen, but it's step by step. So we have now established this partnership and an understanding, and we have the workflow as you see here, just kind of keeping it simple here. So basically what happens is our Rush at Home provider, and we have many that go out into the field on our west side of Chicago here to provide support to older adults and their caregivers. And so they are out in the community, in the homes, and so they are identifying then that care recipient that may have one of those diagnoses, one or more of those diagnoses, and then kind of acknowledge or identify that they could benefit, the caregiver could benefit from training. So then they discuss that recommendation with the dyad. Of course, the care recipient, the older adult, has to give permission and a consent for their caregiver to receive some support and training because their insurance will be getting billed. So there's that discussion again within the home visit, and then if there is consent is provided, then that Rush at Home provider refers to our model here at Rush and enters that consent has been provided. Then one of our team members, when we are licensed clinical social workers within our department, and then we will reach out to that caregiver. We will describe the available trainings and really kind of talk about what was identified by that provider and then schedule a training based on those needs. And generally it will be around whatever symptoms that they're seeing from the older adult. We'll be kind of focusing on training around how to best manage that. It could be about communicating. It could be about modifying the environment and just building those skills so that that caregiver feels really well supported and has tools and a guidance on how to really support their older adult and their well-being. So then, of course, the clinician will meet with the caregiver, provide the session or sessions as needed, because it could be more than one session, depending on what is required and what is needed. And then, of course, that social worker clinician will also then bill in the older adults to the older adults patient insurance. Next slide, please. So the codes that we will be using for individual caregivers that we will be working with are the codes that you see here. I know that they were mentioned earlier. And again, it's really to help the caregivers manage or modify behaviors related to their condition. We do have to have consent from the patient. So that is really up to the provider to get. And then we will be confirming that when we make the call and outreach to the caregiver as well to ensure that the consent was received and it's well documented. Next slide. If we have the opportunity to do group training, so we might identify several caregivers that have been referred to us that really fall under the same needs, identified needs, then we can do a group training and then we would use the codes that you see here. Of course, these are all, even the previous codes are time-based. So there are certain codes that are used for the first time period, and then as additional time is needed, you would be utilizing those additional codes. And for the group training, you can see that the minimum of 31 minutes of time is required. So that initial session for group training is up to 60 minutes, but you have to at least provide 31 minutes to be able to bill for that 96202. Again, patient consent is required. Documentation has to kind of really match to what is in the older adults care plan. Like how is the training supporting that older adults care plan and their compliance or their, with that care plan that's been implemented for them. Next slide. So we can do it in a variety of ways. It can be verbal instruction. We can utilize video. We can use live demonstrations. This could be either individual or group sessions. And again, just really, we like to use a practical approach on skills and strategies. So we do a lot of role playing when we would be providing these trainings, role playing so that people can really have some experience, hands-on experience with doing that and how to react in certain situations, communication, responding to, repetitive speech or, various things that may be occurring. And just really kind of working to reduce any of those negative impacts that may be occurring, both for the older adult and for the caregiver, and for that shared environment. Next slide. So again, these are meant to support compliance of the older adults' treatment and their clinical plan of care. That's really important. And I'm going to actually put in the chat if I can. Give me a second here. Let's see if I can. I have an example of, now this is just an example. So, just like a framework of a potential note that would go into the older adults chart that gives you an idea. of what they might say if they were referring someone over to caregiver training. Because it does have to be well documented. And then when we chart as well, we have to be able to say how we supported the need of that older adult. Okay, next slide, please. This is how you can contact us. We are available to provide technical assistance with this. We are not claiming to be experts yet, but we will always be willing to share our learnings, what we've faced so far, some of the challenges, some of the things that we had to do operationally and work with other departments to make this happen, and our vision for the future. So happy to do that. Please contact us at any time. We are available to all of you as we work to support caregivers. And as I close out, I just want to also honor Anita and her sharing her lived experience, as well as all the other family caregivers that are on this call. Thank you. Passing it back to Dara now.
Thank you so much, Diane. And thank you, Rita, Juliana, and Stephanie for sharing your individual efforts and the research on increasing awareness and putting these codes to practice and providing support for family caregivers on the ground. There's been a lot of questions that have come in, so we'll dive right in. And in efforts to try to answer as many, I'm combining a few. And so for the first one, I just want to also call out the fact that thank you, Anita. Share my gratitude for Anita as well. And then how your story really resonated with so many of the folks in, excuse me, in the webinar and sharing their chat, the chat activity with you all. So the first question is around kind of what, and I'll throw it to all four of you at AARP and Rush. What clinical settings are better positioned to leverage these codes? What kind of TA capacity is needed for these settings? And especially this person is interested in kind of the outpatient setting, including programs like PACE. So it's one question with a lot of different parts, but I think that you can all chime in for this one.
I'm happy to jump in and start if that's okay. I'm chomping at the bit, as they say. Great questions, of course. So if we're looking at kind of an outpatient setting, I would say your dementia care, any geriatric care, maybe your movement disorders or behavioral health clinics. I think that would be good starting points. I'll say that also if you have an established connection with any or all of these or a particular clinic, that could be helpful. I think us having such a well-established rapport and track record, if you will, with supporting our Rush at Home program, I think that was really helpful. And it still took some time just because there's so many competing priorities. But who are those champions that, or folks that you think will get it, or that want to support caregivers and just need a starting point or needs some push to get going. As far as PACE, we would love PACE to consider including caregiver support services as part of their comprehensive care for adults. We'd love to see that now folded into what they already offer and as an add-on and included in their payment system. Apart from that, I think that would mean there'd be folks on the outside willing to support those caregivers that are supporting the PACE participants kind of as a separate entity. I know we do that with Caring for Caregivers is available to support PACE programs and utilize those CTS codes, but that's a bigger conversation that I'd be happy to have with the person that asked that question. And then lastly, I'll just say what TA's capacity is needed. Really, we're happy to help in that area with you as you're journeying into this and talk to the folks with you. But really, it's anyone in your organization, yourself or others, that have some caregiver experience and can make the case. because it's a little bit of a challenge because it's not a big payout. I think somebody might have mentioned, we're not getting a big revenue for this, but hopefully that will come. So I'll let others share. Thanks.
Yeah. Oh,
go ahead, Julietta.
I just would like to add to that on Diane's last point of there needing to be a sort of caregiver expert or advocate. That's really been, I think, a key difference in the programs that have able to be to get these up off the ground a little bit quicker. I'm hesitant to say that one setting is better than the other in terms of starting implementation, just because whether you're an individual physician in their own practice or within a larger health system, we're learning there's going to be some hiccups or gaps. So really having that one person dedicated to pushing it forward with the caregiver experience. And then also operational experience, like Diane mentioned, someone in the system or knows the tech kind of behind that will make the business case a little bit easier to move along.
Thank you. And that is a really good segue into our next kind of categories of questions that came around the CTS codes in terms of the providers that are currently eligible to be reimbursed, the rate of the reimbursement, and who is in and out. And so there's a couple of questions here about kind of the caregiver health risk assessment code and how low that is, and any advocacy around increasing that. And then thank you, Juliana, for answering the questions that were coming in about the type of providers like chaplains, like community health workers. So this big question is kind of what's next for both in the advocacy efforts with Rita, you and Juliana, folks at AARP, and then for you, Diana and Stephanie as well, kind of what's next with these codes, knowing that they are a great opportunity, but there's some limitations or several limitations to them.
So I'll jump in on the advocacy side. We do recognize, and we've heard both when we've had our own meetings, as well as we're looking to work with provider organizations about the reimbursement and how low it is. One of the things that we talk a lot about is that many of the things that are covered even at a lower rate are things that providers are already doing. And so that's one way to look at it is that now, even at a lower rate, you are able to receive reimbursement, but we do recognize that there is opportunity for movement in that space. And so AARP, as well as we know a number of provider organizations are very much looking at, what differences can be made in that particular space. So it definitely is something on the radar.
And if I could add to that too, of course, the payment is one way to advocate, which of course we would like the payments to be higher. Another way that we are hoping to really advocate for, these codes, one, but also just more usage is through increased access. And this ties back to the point Anita made in her discussion of her real experience, where these trainings really can be utilized across the care continuum. And if there's a way for us to increase the eligibility, eligible providers for those already doing the work, if there's a way for us to increase the amount of times we're doing these trainings so that maybe they aren't as high of payments, but we're doing them more often, thinking of, those sort of ways to push it forward, while we still, of course, advocate for higher payments.
Great. Thank you. And we have about a minute or so before I close this off and share some closing remarks, but I want to bring up Anita back to the conversation. And Anita, the question that we have for you is, you talked about your experience, what it meant to not have the training, adequate support. And so if hearing about these policy changes, you talked about how a big difference they would make. I just wanted to give you some space and opportunity to share kind of your any reflection around the work that it's happening and really kind of bring it down to what this means in real life for family caregivers like you.
I just think it would make a tremendous difference in the confidence of the caregiver as well as the well-being of the person that you're taking care of, because it would enable you to do the job versus just figuring out in real time. Just something as simple in my case, I could have prevented strains on my body and discomfort with my mom with just mobility training. Um, we go from canes to walkers to wheelchairs, but then in small spaces, there's navigation issues. And you're just learning in real time. When you get that equipment, you just get the equipment, but you don't learn the navigation that goes along with that. And I think that just can make a difference in just the well-being of both parties and the just the overall outcome of the health for everyone. So I applaud everyone whose hands are involved in this whole process, and I just hope and pray that it gets expanded beyond where it is now because it will make a tremendous difference.
Thank you so much for for those words, and really sharing like really clearly why this is so important and why it matters now, and why we must continue to advocate and work for it to be implemented, to be expanded, and to really fulfill the needs of family caregivers across the country. So with that, if we can get our last slide, there's a lot of questions that we didn't get to about advocacy efforts. And so just want to make a plug for NAC that we do submit a comment to the physician fee schedule every year where the proposed changes to the CTS codes are posted in July. And CMS accepts comment letters and sign-on letters, and we'll be working on those. I really encourage you all to reach out to us. In the past, we've done some work in terms of all family caregivers as part of NAC, and then as part of our very specific cancer and transplant work efforts, submitted letters on behalf of cancer caregivers and transplant caregivers as well. We also developed template language for you all to submit comments directly. I know there was some state-specific questions and issues that were raised during the chat, so definitely encourage you all to check these out and connect with us, as well as the resources that our partners here in AARP and Rush have mentioned. We will be sharing the recording. Also encourage you to check out our last session where we had partners from UCSF. One of the questions was here around any resources regarding these CTS codes. So these resources, they're growing. We're actively working to expand those and get those to different partners and health systems around the country. So definitely reach out. So with that, I just want to thank all of our partners again. Thank you all for tuning into our webinar. Excuse me, and of course, all of our sponsors who make NAC and NAC's work and our Cancer and Transplant Collaborative work possible. Thank you all.
Thank you all.